Hi, everybody. Thanks for joining. This is the February 2025 Virginia Tech Carilion Wilderness Medicine Journal Club. This month's session is going to be on frostbite. We are going to be covering the 2024 updated WMS frostbite guidelines, and we're going to somewhat tag on an associated topic in 2 months. We're going to transition to trench foot and like a tropical trench foot at that time. I just wanted to give us a break for a month, and we'll get back to that. So Brian Roach is going to be presenting the guidelines for this month. I'm going to mute myself, and I'll be in the background. Brian, take it away, share your screen, and the floor is yours.
Okay, thank you. Stephanie, Justin, anyone, feel free to jump in at any time and if you have comments, but I've got about 20 or so slides. Let me see, no share screen. Wait, hold on.
And if you're having trouble with it, you sent it to me. So if you need me to, I can share my
Yeah,
screen if you need me to.
where's my share
You might
screen?
have to make him a co-host, Justin, because I don't think for regular us plain
Oh, because
members
I'm
get to
like a
choose.
backup host now, aren't I? All right, Brian, you are now a co-host.
Okay, now let's see if I can share.
Yep, it should.
Okay. Okay. All right, can you see that?
Yes.
Okay, so I've got about 20 or so slides on the clinical practice guidelines that were published in 2024 by the Wilderness Medical Society. Let me see here. So in about 2010, the WMS put a panel together to work on guidelines for frostbite. I'm not sure what exactly happened between 2010 and 2019, but the guidelines, I think, were first published in 2019. And then last year they were updated. And in the update, they didn't really get specific as to what changed. But they did say that they're following sort of the recommendation criteria followed by the American College of Chest Physicians regarding the strength of the evidence, the recommendations and the strength of those findings. Who I am, I'm a newly minted nurse practitioner. I was in the ED at a hospital in Connecticut, and I'm soon starting a job as in the ED up in Maine. I'm nearly done with my FOM, and I've just gotten going on the dive and marine medicine diploma. And for the fall, I did a lot of fun things. Did about a week's worth of rock climbing in New Hampshire. I went on a few scuba trips in the Red Sea and the Bahamas. I did rim to rim to rim in a day, and I saw all the major pyramids in Egypt, among other things. But those are some of the highlights. So the clinical practice guidelines, there's the contents. They talked a bit about the pathophysiology of frostbite, and then they went to the classifications, discussed the prevention, and then they had some recommendations regarding field treatment of frostbite, and then sort of the recommendations for immediate therapy in the hospital. And then they had a few comments about other post-thaw therapeutic options. In terms of the pathophysiology, they described it as sort of 4 overlapping pathologic phases: pre-freeze, freeze-thaw, vascular stasis, and late ischemic. And they sort of are they're like a cascade of events that where there's crystals that are forming that eventually lead to cell death, and the constriction and dilation of the blood vessels lead to sort of tissue ischemia and ultimately infarction. And as we'll see, it can get kind of nasty. The classification of frostbite, they go first, second, third, and fourth degree, where first degree is sort of numbness and erythema. And then second degree, there's you start to see some blistering, and in the fourth degree, the very deep blistering, hemorrhagic blistering, and then in third degree, and then fourth degree, very deep, with ultimately necrosis into the muscle and bone. This slide is the only page that really is not coming from the clinical practice guidelines. This is just a the best illustration I could find of what first, second, third, and fourth degree look like. And but when we talk about sort of frostbite in the field, we talk about superficial versus deep, and superficial is typically classified as first and second degree, and deep is commonly known as it covers third and fourth degree frostbite. So frostnip. Frostnip is sort of the precursor to frostbite, and it's what many people experience when they think they have frostbite, where they're feeling very cold and there's some pain and numbness in their fingers, toes, ears, nose, but there's no ice crystals being formed, and there's no risk of tissue loss with frostnip. And it usually frostnip resolves quickly with warming, but it's sort of a signal that potentially frostbite would be coming if actions aren't taken. The guidelines discuss 3 categories of frostbite prevention. First being maintaining peripheral perfusion. They discuss exercise and protection. With respect to sort of peripheral perfusion, you maintaining core body temperature and hydration, understanding sort of your disease and medications that might lead to it might affect perfusion, things like smoking or certain drugs that may cause vasodilation would cause some people to be more susceptible to frostbite. Covering skin and scalp to insulate from the cold. Minimizing blood flow restriction, like tight clothing, tightly tied shoes or tight socks. I'm sorry. Ensuring adequate nutrition, and if in situations where hypoxia is a risk, using supplemental oxygen. So per exercise, I think I have a typo. I'm sorry. I'm sorry. Exercise helps with vasodilation, increasing the core body temperature, also increasing peripheral temperature. And the caveat here is that exercise when someone is cold is using up their remaining energy and could lead to exhaustion. So exercise is a good prevention technique as long as it doesn't ultimately cause the person to run out of energy. And thirdly, protection from the cold. These are some of the similar comments that were made regarding perfusion. Is that protecting from the cold, avoiding perspiration in wet extremities, making good decisions, and with regard to sort of being aware about the cold. Making good decisions about alcohol use in the cold, being aware about how you're doing yourself and also other people in your group, being smart about sort of minimizing cold exposure, and increasing insulation when appropriate. I gave an example of like switching, from gloves to mittens, using chemical heat. And as I said earlier, recognizing frostnip because that's a precursor to frostbite. Just the grading system that used, just to sort of refresh folks' memories. There's a sort of a strength portion and a quality, and recommendations are either strong because where the desirable consequences clearly outweigh the undesirable consequences, whereas a recommendation is weak if the consequences are considered to probably outweigh the undesirables. And then with regard to quality, there's high, medium, low, and very low, and that has to do with sort of the whether there was random controlled trials or not, whether there's limitations with those trials, or whether it was just observational data. So one thing about sort of the Frostbite clinical practice guidelines was that there was a total of 38 sort of recommendations throughout the document. And as you see here, I just sort of, because it just kind of to step back, when you look at sort of the recommendations, there was only 3 that were sort of like strong recommendations with moderate quality evidence. But for the most part, the rest of them, the other 35, we either had low or very low quality evidence. Some were considered strong and some were considered weak. But for the most part, there was no high quality, because obviously it's very hard to do trials when you're dealing with something like as serious as frostbite. So as I just said, yeah, there was total of 38 recommendations in the guidelines, and a little over half of them were considered strong, and only 3 of them had sort of like were either trials or exceptionally strong evidence from observational studies. And so those 3 are where there was strong recommendations and moderate quality evidence. Was the exercise to maintain peripheral perfusion, don't rewarm if there's a risk of refreezing, and rapid rewarm if you're able to stay warm. And rapid rewarm, the guidelines is using water that's between 37 and 39 degrees Celsius is ideal, and sort of monitoring that water and trying to soak the frostbitten extremity in warm water. And those are the 3 things that sort of are where there's the strongest sort of guidelines is, yeah, exercise, not to rewarm if do any sort of rapid rewarming if there's a risk, you're still out in the field and there's a risk of refreezing. And when you can rewarm and stay warm, rapid rewarming in warm water is the best. So some of the other things in the field, so that when they talk about field, they defined it as sort of being greater than 2 hours from definitive care. And so some of the other recommendations, there was a total of 12 of them. First is always to sort of treat hypothermia or treat the trauma as sort of a precursor to sort of dealing with the frostbite. Second, if there's any sort of tight clothing, as I mentioned with regard to perfusion, maintaining good perfusion. If there's jewelry or anything that's sort of extra or too tight, remove that. Number 3 is, as I just said, is sort of like assessing whether there's a risk of refreezing, and then you make the decision whether to sort of do a rapid warming or passive warming. And passive warming, examples of that is sort of like putting, if it was a cold fingers, putting them, under your arm or, up against sort of somewhere else, somewhere like in the core, touching warm skin in your core body. But something where there's passive warming that where you're warming sort of much slower. They discussed using ibuprofen to sort of help with reducing inflammation, managing pain. If the body part is wet, to air dry it, don't rub. Rubbing can cause additional tissue damage. Once again, protect from so if there is a sort of a passive thawing going on, or an active, is to avoid refreezing. Topical aloe vera, there was that was sort of a weak recommendation. If there's blistering, dry, bulky dressing would be okay. Elevating the extremity, maintaining hydration, and protecting the body part. And they discuss specifically, like if there was a frostbitten foot, don't attempt sort of ambulating, because that could cause additional tissue damage. With respect to sort of in the hospital, once again, the priority is always to sort of treat the hypothermia or the trauma before focusing on the specific frostbite. In the hospital, rapid rewarm is the number one sort of strategy for dealing with the frostbitten body part. Once again, ibuprofen, pain control. Tetanus was recommended. Once again, air drying, don't rub the body part. The debridement was something that was considered. They suggested that if there was blistering, that if it was clear, to drain it, but if it was hemorrhagic, to leave the blistering. Once again, topical aloe vera, dry bulking dressing, elevating the extremity, hydration. And then there was some discussion about thrombolytics, miloprost therapies to help with if there was tissue damage and vascular damage, and to get a clinical exam. And with regard to sort of other post-thaw therapeutic options, there was a brief sort of discussion about hydrotherapy, hyperbaric oxygen, imaging, sympathectomy, which is, I guess, the sympathetic nerve surgery, hospitalization, fasciotomy, and consider surgery for amputation. But all these the recommendations in all these cases are weak, and there's not a lot of data supporting them. So the most important things is if someone appears to have in the field and appears to have frostbite, movement, getting the body warm is highly recommended. It not only gets the core body temperature, but would warm the cold extremity where the frostbite is setting in, improves vasodilation, and there's strong evidence against not rewarming if there's a risk of refreezing in the field. And if there's not a risk of refreezing, to use a rapid rewarm if you're able to stay warm, with warm water being the ideal way of doing that. And so that's the clinical practice guidelines. Is there any comments, questions? That was kind of quick.
Yeah, very thorough but concise. And if there's baby yelling in the background, bear with it. That's why I had my... Sorry about that. Great job. He asked, any questions about what you would do with the patient if you had a frostbite patient in the field or in the ER based on what you just learned?
Yeah, so does anyone here, are you guys using iloprost up in Maine at all? I think the interesting thing is after this practice guideline came out, iloprost became FDA approved in the United States, which it hadn't before. So pretty cool.
I haven't started working yet, and I have not seen, there's a lot of cold people in the country right now, but I'm not familiar with that. Yeah.
So iloprost is typically used for like inhaled iloprost for pulmonary hypertension. So that had been the previous only use in the US and Europe and Canada. They've been using it for frostbite with some pretty good outcomes. Yep, Canada, you guys are leading the way in this for sure.
Yeah.
Maybe more cold people too. So the challenge in the United States right now is it's actually a very expensive medication because the formulation for pulmonary hypertension is inhaled, but it's IV for frostbite. So actually getting it is pretty challenging. In Virginia, we have had one case that was a patient that had trauma, so giving lytics was not a reasonable option given the significant trauma she had. But iloprost was something that we considered. The challenging thing is it's not stocked in our hospital and was not stocked in any of our like regional hospitals. The closest we could find it was a distributor down in Greensboro. And then it's got a pretty hefty price tag as well. So interesting, not on formulary kind of thing. I spoke with one of the critical care doctors up at UVA, and interestingly, they've actually given it in their ICU and do have it at UVA. So that was a good learning point. Let's see, Matt, you want to tell us a little bit about, have you gotten to experience it clinically?
Not myself, I wish. I just know that there's been a couple of trials up here, up in Canada, and they're using it pretty much across the board, BC, Alberta. I'm working in Ontario myself, and albeit in southern Ontario, so not dealing with as much of the cold temperatures. Trying to pave the way because a lot of our staff here aren't sure of a lot of the indications for it. So trying to do a little bit of some quality improvement projects for the treatment of frostbites that we can see hopefully some better outcomes and better utilization when it does get pretty cold up here.
Yeah, that's
Hey,
awesome.
man, one of the articles that I almost chose was written by a group in Canada where they were speaking with different facilities from each province and trying to come up with a interprovincial frostbite consensus as well as like recommendations. Have you heard anything about that throughout Canada?
Yeah, on our version of WMS, it's the Canadian Association of Wilderness Medicine. It's been like a recurrent talk that comes up every year, pretty much like a different provinces coming up with, we're trying to come up with like a new study kind of demonstrating its utility within Canada. And then I know that there's just like that working group that's kind of behind the scenes trying to make those recommendations of like the ileoprost is like usable within like 72 hours of onset versus the thrombolytics is more of a 24-hour piece, and trying to make it a standardization and a bit of like a widespread quality improvement group. But yeah, that's kind of the extent of the knowledge that I know. It's just kind of like talked on and trying to be slowly disseminated within the country.
Yeah, the article was basically just the initial phase of trying to get everybody interested and like showing that it's a needed resource, but I couldn't find a follow-up about whether it became an actual organization yet. When you mentioned the timeline for iloprost versus the timeline for TPA, there was another study that's in the Google Drive for this session about a study on iloprost in Kathmandu. Makes sense because it's hard to get somebody off Everest and then promptly to a facility where you can give TPA within 24 hours. So their study it showed good outcomes using iloprost, and so they have a protocol in Nepal for using iloprost. So the great US of A can't give quite necessary medicine, but hopefully it becomes more widely spread and cheaper soon. Has anybody, let's more so focus on students and residents here for a minute, or ACP students. Anybody treated a patient with frostbite firsthand? Okay. I have a couple firsthand experiences, one particularly that I remember from residency, and then a handful I've had here in Virginia. So, Matt, I know you say it's nice and warm down here in the States, but we still see frostbite here. So I did my residency training in Detroit, where it's pretty cold. There's a lot of homeless people. So I had a patient came in over a night shift, homeless patient. He kind of refused to have the lights on because he was kind of like, I don't know. I don't want to say he was an addict, but he kind of fits that vibe, or he's out on the streets coming in for the cold for a warm environment. He didn't let us turn on the lights, and he didn't want to take his clothes off. Eventually we turned the lights off. We're like, hey, we got to get you in a gown. Took off his like socks he was wearing for gloves. And then we saw he had clear fluid-filled blisters of the distal phalanx of like every single digit. I don't remember it going past the like distal phalanx. I think it was pretty much distal, but it just goes to show what happens, why it's so important when you examine patients to turn the lights on, whether they want it or not. Disrobe the patients, do a full head to toe skin exam when it's indicated, because if we hadn't pressed the issue to like head to toe examine this guy, we would have missed frostbite. So it never progressed past first degree. It never passed the distal phalanx. So, Brian, I think you mentioned it. So clear fluid-filled blisters, distal phalanx only. Brian, did you mention like the staging as far as proximity on the hands and toes?
I didn't. It was in there. I didn't.
Okay. It's a lot. It would have been really dense, but basically it makes sense. The more proximal up your hand, closer to the body, more important, more they call it higher severity. So his never went towards even the MCP. And he, as far as we know, he was lost to follow-up. But as far as we know, he was okay on discharge, but who knows what happened to him. So basically, if you have a patient in your ER, you have what you think is first-degree frostbite. How do you want to rewarm it? We talk about doing the rewarm. How do you want to do it?
If you guys click on that Yukon site that I put in the chat, it has some pictures with the different grading as far as proximity and
Yeah.
blisters and stuff. So it's just kind of nice to have a picture to look at.
Why don't you pull that up and you can think about the proximity and you can think about severity and all that. But I think it's a good point to talk about. Like we talk about rewarming, but how do you do it? How do you want to warm these people up in your ER? Okay, so as mentioned in the guidelines, you want constantly recirculating water, right? You don't just want to stick them in, like, you don't want to just shove their hand under the sink. So how do you know if it's appropriate temperature water? If you don't, I mean, you were just going to sit there with a little rectal thermometer and just like stick it in the sink. What do you think is an alternative way to doing that? Or if you have a thermometer from home, what can you do as the provider to check to see if it's good temp? Bowly, sure. You could just put your own hand in there, see if it's tolerable but warm, hot but warm. You could have the patient self-monitor. If they have unilateral frostbite, they could use their contralateral hand or foot and see if it's tolerable but hot. But how are you going to get constantly recirculating water? Let's particularly focus on hands for a minute in the ER. I'll tell you what I did. Maybe somebody has a better thought. Luckily, there's a guy's hands, so he could stand up. I just put a vomit basin in the sink, turn on the water, and let it flow into the tub. So then it would flow into the sink and have constantly recirculating flow. And I just monitored with my hand, and I had somebody hang out with him. I saw students, they're great. I had a student hang out with him just to make sure the temperature was good. I rewarmed there. You need a constantly recirculating, constant temp, tolerable, warm tub of water. Anybody else done something like that with a better idea? Blood rewarmer tubing. Well, like wrap it around their hands with the device.
Well, you could definitely, I guess you could take like the level 1 and you can actually set a temperature. So like when we rapidly transfuse blood into trauma patients, we know trauma patients don't do well with cold things. So we rewarm the blood. And you can do it like through a hotline and you could set a temperature.
Yeah.
That would definitely be a way to do it. The way that Wake Forest does it is with the cooking device, the sous vide. And they put the sous vide in a basin and they set the temperature on the sous vide and it circulates the water. So pretty cool.
Yeah.
And you can use it for hands or feet. And I think they're using them as single use just because there's not a great way to clean them, but figure some chlorhexidine water and it probably will come pretty clean. But that's definitely an option. I think there's a couple studies showing that that's efficacious for keeping water the right temperature. You just want to keep the people from, trying to stick their hands in the sous vide.
We just need some type of large tub for the foot. It'd be hard to get that in the sink.
Yeah, just like a rubber basin. Well, even there's like
Yeah.
rubber basins or something.
Yeah.
Or
there
if
was
you're
a
set up to
study-
do this a lot, having a big basin would be great.
Yeah. There was a study, it's in the folder from like 2021, or when we covered frostbite the last time, that talks about a sous vide study in an EMS protocol. Oh, it has been using. Yeah, cool. Couple other cases I've had, not as the first provider, but as like, I guess I'll call them bounce backs. So over the past couple years, I've encountered a couple bounce back patients. So one that I pretty starkly remember was again, it's homeless patients. We see it all the time in them. He was living in his car with no gas. So basically just a shelter that's no warmer than the outside other than no wind. Came into the ER, so saw a provider for foot pain, discomfort. He was diagnosed with athlete's foot. and discharged back to his car, where he had to walk because in the town I work, half the time there's no public transport, Uber, or anything like that, not even a taxi. So you have a homeless patient with like cotton socks, basically sandals, middle of the winter with temps persistently overnight being sub-zero. Below freezing. That particular stretch of days was like in the teens. I was a little hard pressed to think about how that would have been athlete's foot personally, especially when I took his socks off. Again, I'm not entirely sure they even looked at his foot. But if you have a patient where there's like no homeless shelter, no ability to send the patient to like a hotel, and no means of transport, technically talking to a hospitalist, no admission criteria, what can you do for a patient like that you find out had frostbite? I'll tell you, there's not much. So I basically held on to him, educated him, gave him as many like toiletries, and I snuck him a blanket and like got him a bunch of socks. By the way, I can tell you those hospital socks are awful. I've worn them recently. They are not warm. They're horribly uncomfortable. We let him sleep in the ER overnight. We let him sleep as long as we could in the day until we could find something. But there was like you said, Stephen, there was just like nothing. And nowadays, with no insurance coverage, nobody wants to take care of the indigent. There was no admittable criteria. I just kept him as long as I possibly could. And this was like 3-4 years ago. But I've seen that same year 4 other cases of missed frostbite. And not by the same provider that was missed at 2 separate hospitals. So I'm not sure why in the world there'd be a homeless patient in the middle of winter that was diagnosed with athlete's foot, but I saw it 3 times in one season. So I don't want to say it's easily missed because I caught it. I'm not saying I'm that smart. I'm really not, but maybe it's because I studied that topic the year before or something. But I just want to really press on you to like actually look at your patients and do an exam, and just put context clues together. So there is a homeless shelter in town. There's warming shelters. Think of any resource you got. Like Steven said, find anything. Unfortunately, this guy was otherwise healthy. And he had already rewarmed. So what are you going to do for a patient after they've already rewarmed? You can't rewarm their foot. It's warm. So just remember that in your low resource facilities, even your high resource facilities. 3 of the patients were at a 750 bed hospital. Any other encounters with frostbite? I've never seen the hemorrhagic bullae myself. I've seen the clear fluid filled. You just, like he was saying, you just pat it, make sure there's no rubbing, make sure they get follow-up. Of course, my town also had no wound care, no podiatry. At that time, no general surgery, nobody. So
What do you guys think? When do you amputate? Like, is this something you want to call podiatry to go ahead and cut off those toes, or what do you think? So I always always think about it. There's an old adage, I think, that's like freeze in the winter and amputate in the spring or summer, because a lot of times you'll have really gnarly looking tissue that will look necrotic or look dead. And if you amputate early, what you'll end up doing is actually cutting off viable tissue that will reperfuse and will do okay. So some of these patients, kind of like snakebite patients, you kind of want to protect them from surgeons in a way. So you want to give that frostbite time to declare itself and figure out where it's going to actually demarcate, because sometimes things that look dead aren't actually quite dead, and you can save a lot of valuable tissue for people walking and having mobility and things like that in the future. So remember, when you see frostbite, it's a medical problem to start with, and you want to let it declare itself before you get a surgeon involved. And surgeons that are in places that see this a lot are very aware of that. When you come down to places like Virginia and in the southern United States, they don't see it as often, so they see something that looks like, it honestly looks like, an ischemic kind of foot or a gangrenous foot. They get excited to cut things off.
like she was saying, they let them last weeks and weeks, if not a couple months. they basically let it turn to dry gangrene. Like if you Google it, you'll see people, they'll show videos of them moving their proximal to the dry necrotic tissue, and they'll just be moving their fingers with mummified looking fingers basically, and then they finally wait for it to demarcate, and then they amputate distal to that. They can also do angiography, but it's sort of prognostic. I'm not sure it really changes things, but it's good to do it before and after the TPA. The studies on that's pretty cool. Any other questions, or is there any concern with infection leaving the tissue? So there was one study that's in this journal club session. There was a patient. It was one out of the entire patient population in that Kathmandu Ilapro study that got infection. They just said it was like a mild cellulitis, and I can't remember the antibiotic because it was in like the international name. I can't remember what it was. It's like calling Tylenol paracetamol. And they recovered beautifully. They don't usually get infected. You just give tetanus and clean it really well on the without rubbing on the first encounter.
I imagine some of it will kind of depend on your patient population too. If you're dealing more with, people that don't have a lot of resources or undomiciled, they may be more at risk for infection because they don't have as good of ways to like do wound care and keep things clean. So it's definitely something I'd have a high suspicion to. I wouldn't necessarily like prophylactically treat them for antibiotics. Some of the cases I've seen here, you're looking at it and you're like, is this trench foot? Is this an infected diabetic foot? Or is this like the sequela of frostbite? So in those cases, I've erred more toward treating with antibiotics, especially for people that I'm not 100% sure have amazing follow-up. But that's being more conservative. I think it's a lot of different patient populations. A lot of the studies that are done are on, athletes and mountaineers and people that are a lot different than the patient population that we see in more urban and suburban areas. And you think about it, it makes sense. Like, you're poorly controlled diabetic who is a smoker and has peripheral vascular disease and, taking high risk medications and is drinking alcohol is going to be at really high risk for frostbite because they don't have good perfusion to begin with to keep those extremities warm. And sometimes they don't have the sensorium to know when things start getting cold if they already have peripheral neuropathy and things like that. And then they're more at risk because they're just not going to have a good healing process because the vessels they have are not great. Where the people we traditionally think about in wilderness medicine are your top athletes that are climbing in Nepal and doing crazy things, and they've got great vasculature, a great chance of healing, will probably take better care of themselves. So just really different patient populations with the same problem that kind of manifest differently.
So before we talk about anything else, I just wanted to see if there's anything else you want to talk about the guidelines or any other case presentations or questions you have about patient care for this. Okay. So I think that can wrap up our discussion for frostbite. And I know that might be a little early compared to typical. I wanted to just advertise to all of you here how important it is that there are volunteers like Brian who step forward and volunteer their time to present and review articles and present topics like this. I've had a rough 2 months with family emergencies and orthopedic injuries that I've not had the time to send out emails and Instagram posts looking for volunteers. So if you're ever interested in presenting a topic, anytime in these next couple months, please proactively email me or sign up on the registration form that you're interested in presenting. I just didn't have the time to send out repeat posts looking for help. So thank you, Brian, for presenting this topic for this session. I had put 3 or 4 other articles in the Google Drive for you to please read, and I hope you learned a lot from that. I think I read 5 or 6 articles like I typically do every month. So if you're ever interested, please just, she just put my email in there. More than happy to get you to present. It's useful to your FOM process. And participating in a session gets you a participation FOM credit, which you can submit for free. If you present, you can put that on your elective application for FOM because you have to have both teaching, experience report. You have to have both teaching, presentation, educational, physical training, all that kind of stuff to get your phone. And presentations get you that experience report credit. So please volunteer so that we can have articles covered in addition to CPGs. There's been a couple times I've taken the time to present as well, but I mean, I work full time and I organize this, and I just don't have it in me to present every month. So if you're ever interested, please let me know. That being said, next month's topic is, I think I called it the female adventurer. We're going to be joined by a couple members of the Women in Wilderness Medicine Committee from the WMS, and they're going to talk about basically all things of women in the environment as their own experiences, adventuring, teaching, leading trips, as well as how you take care of patients with anything related to any potential female specific conditions. And like I said earlier, we're going to touch base back with trench foot and tropical trench foot in April. So hopefully you join in and we can kind of tag these two together to talk about how you can differentiate them, because you can be cold and wet, not just cold. Otherwise, hopefully see you next month, and I'll see you soon. Thanks for joining.
Can I make a couple shameless plugs if you stop
Please
recording?
do.
The Student Wilderness Medicine Conference is coming up in the beginning of May, and I'll put the link in the chat. So please, this is the 18th annual Student Wilderness Medicine Conference. If you are a student or want to be a student or just like wilderness medicine, come join us. It's $30. It's up in Fayetteville. You get a t-shirt, lots of awesome education. We'll probably be running a Swiftwater course on that Sunday, so kind of watch the website for those advertisements. And then since Justin kindly gave you some of your evening back, another shameless plug, we're doing a research study on multiple choice questions in wilderness medicine. And if you're interested, I'll post the link in the for our test. Know that this is a test that is not validated, so don't use it to like learn things. Find it in my email. But something that we're working on studying, and if you'd like to participate, we'd be happy to. And hopefully I can find it. Justin, do you have it by any chance?
Right. Let me see. Yeah, I'll have it on my oh. Sounds good, Stephen. That was the one you wanted me to post to the committee, right?
Yeah, not the podcast one, the other one.
Yeah. Hold on, everybody. Sorry about that. We're gonna give you
Yeah,
something.
you can jump off if you don't want to do it, but it's fun. It's like 45 questions, and you'll know how much you know about wilderness medicine. There we go.
You just want, oh, you found it?
I found it. Yep.
You beat me. Okay. I found it too.
So it's 45 multiple choice questions. And I'll share the results with this whole group afterwards, if you're interested in doing it. It won't take you very long. It's about the questions, so but you'll probably learn something along the way.
And just in case you guys all lose it, if I have that email, Steph, I can just post it on the Instagram page if you're cool with that.
Okay.
Cool. All right. Well, thanks anything else, Steph? I know we're doing a lot of cool stuff soon.
Yeah, we also have a wilderness medical provider course that's going to be coming up in May. So for those of you guys who are interested, just kind of watch the Blue Ridge Adventure Medicine website, because we've got a lot of cool stuff coming up. We've got some wilderness first aid classes in the area that are coming up. So if you're in the Roanoke area or can travel here and are interested in teaching or hanging out, we've got all sorts of cool stuff coming up. So yay for winter being over.
Well, it came back today, but
It did come back today. I either want like 2 feet of snow or no snow.
yeah, we got like 2 inches. All right. Thanks, everybody. I'll see you next month. Like I mentioned, female adventure, and I think we'll have some cool basically multi-group involvement. So it should be pretty fun. Bye, everybody.